Welcome to this week's edition of the Medical Center Show. Today I'm very excited to have a wonderful guest, Dr. Jyoti Matta, who is the Associate Director of our Medical Intensive Care Unit and a pulmonologist. So we're going to talk about how to keep your lungs healthy this week. We'll be back in a few.
Newport, the luxury waterfront community on the Hudson River, offers the quality of life you deserve in 10 high-rise rental towers with amenities such as the on-site Newport Path subway, light rail and ferry service, Newport Town Square, 3 playgrounds, dog run, upscale restaurants, retail giants like Sears, JCPenney, Macy's, and Target. Morton Williams Supermarket is just outside your front door. A health and fitness club, spa, skating rink, and medical facilities are also on site. NewportNJ.com. Enjoy the New York skyline from Newport Town Square. Manhattan is just one path stop away or quick ride through the Holland Tunnel. Nursery and private elementary schools all on site. 12-screen movie theater at the Newport Center Mall. Want to visit Newport? Stay at the Westin or Marriott Hotel. Go to NewportNJ.com for details. Newport has luxurious towers, great restaurants, shopping, New York skyline views, schools, playgrounds, a marina and yacht club, gym, spa, fine wine, fine living. It's incredible. It's you. NewportNJ.com. Newport, live like you want.
Seeing the ER doctor at the Jersey City Medical Center has never been easier. If you're sick, you just click. Go to libertyhealth.org, and here's how it works. Click Skip the Wait. Select your time and check in now. Enter your symptoms, your personal information. Click Proceed to Confirmation, and the doctor's waiting for you. The Jersey City Medical Center. Make Hudson County's #1 hospital your first choice.
Welcome back. We're here with Dr. Jyoti Matta, who is our Associate Director of the Medical Intensive Care Unit, a pulmonologist. Welcome, Dr. Matta. We're so glad to have you here this week.
Well, thank you very much for having me here today.
So tell me a little bit about yourself, your education, your training. For our audience, tell us.
Well, I happen to be a foreign medical graduate. I trained in a very esteemed institute in India.
Okay.
And I did my residency training at UMDNJ Newark, which is now going to be a part of Rutgers Medical School.
Right.
And
right.
I think St. Barnabas as of this morning.
Yes.
But I had a wonderful training there. I did my subspecialty training at Robert Wood Johnson University Hospital.
Okay.
And I did my sleep fellowship at Newark Beth Israel.
So you're a pulmonologist. You had subspecialty training at Robert Wood. Tell us a little bit about that specialty training.
So that was a 3-year training with pulmonary and critical care.
Okay.
And then I did an added 6 months of sleep disorders at Newark Beth Israel. So my total training was almost 3.5, 4 years long.
So you kind of do a couple different things, but all related to the lungs. So you're
Yes.
the medical director for our medical intensive care unit, because a lot of people have pulmonary problems when they come to the medical intensive care.
Well, yes,
right?
that's a part of critical care, and pulmonary goes hand in hand. So it's a comprehensive physiology. We're intensivists.
Right.
You know, we take care of all the acute situations that arise. We manage the hemodynamics on a minute-by-minute basis. And it's intertwined with pulmonary.
Okay, so there's a team of people that do that at
Yes.
the medical center?
Yes, we're a group of 3 that do that. We're the 3 intensivists for the hospital. It's a
Right.
closed unit. Every patient that comes in through the emergency room comes under our service, and we handle the management of that patient until they're ready to move on to the medical floors.
And so you have 2 other partners that
Yes,
help
I
you
do
do that. And tell us about the outcomes in the, I mean, patients who go to the medical intensive care unit are probably the sickest patients in the hospital.
They're the sickest patients, and I have to tell you, I think over the last 5 to 6 years, since we've moved into this new hospital, we've had tremendous input from nursing as well to create protocols.
Right.
These protocols have been to manage sepsis. They've been also to manage certain types of trauma, although we don't take care of the trauma critical care patients.
Right.
But we've had a tremendous mortality outcome. I think our mortality is between 20 and 30%, which is slightly below the national benchmark.
Okay.
Our sepsis outcomes have gone down from 45% mortality that was 5 years ago down to 20 to 22%,
Wow.
again, which is better than the national benchmark.
And that's really because you and your team are really keeping a close eye on what's
I think it's the
happening
way
in
we
those
do
medical
things.
intensive
I
care
think the
unit.
way the unit is closed, it's the protocols that we have, it's
Right.
how we function very efficiently.
Okay.
And, you know, we train the house staff to do
So
the
tell
same.
people what sepsis means.
So sepsis is a response that the body produces, and it's usually secondary to an infection.
Okay.
It can be due to non-infectious causes, but once something has invaded the body,
Right.
it's the crazy situation or the inflammatory situation, which is very unique to an individual.
Right.
And when this inflammatory cascade kicks in, there's a whole collapse of the circulatory system.
Oh.
And it requires management in a very efficient manner. It requires antibiotics to be administered right away. And if that's not done within 3 hours, the outcomes can be really poor.
Okay.
So to get that done, it has to be a team effort with the emergency room, with the intensive care, with the house staff, with us, all on the same page.
Now, typically, who would get sepsis? I mean,
Anybody can get sepsis. Any individual can get sepsis.
All right.
It's the genetic build, I think, of the individual patient that determines how he reacts to the trigger.
So patients who come in maybe in acute pulmonary distress or something wrong with their heart, they could potentially get sepsis?
Oh, absolutely. And in fact, if there's something wrong with their heart, then that puts them in the higher, sicker category of patients, because now you're talking about a circulatory collapse in the setting of a bad baseline.
I see. So every once in a while I hear code sepsis in the hospital. What's that all about?
So the code sepsis is what we created about 4 years ago.
Okay.
This is in synchrony with the emergency room. As soon as the emergency room suspects, based on certain criteria that have been well identified in the literature, that an individual could be having sepsis, they activate the code. The team comes together, which includes our house staff, us, the emergency room doctors.
Now, when you say house staff, you're talking about the residents?
The medical residents that we train in the intensive care unit. We all come together as a group, go down to the emergency room, and start the management. Because the whole idea is if it's managed within the first 3 hours, the outcome can be tremendous. And I think that code sepsis is what's primarily the reason that
So there's
we've
a
done
group
so well.
of people that end up focusing on this patient
Purely.
who is suspected of having sepsis,
Yes.
and you immediately start the protocol to get them back
Yes.
on their feet as soon as possible.
Everything.
And so you talked a little bit about the mortality rates as a result of this concerted effort. Tell us a little bit about what happens to patients. Typically what happens to patients. Those patients don't survive many times, right?
Well, but the whole idea with sepsis is the mortality is very, very high.
Right.
It could be anywhere from 50 to 90%, depending on how many different body parts are involved.
Wow.
The sooner we intervene, the less the chance of multiple body parts being involved as the cascade sort of starts to unfold.
Okay.
So the sooner we catch them, the less the better they do in terms of outcome, because we happen to salvage organs.
Well, it's almost like the trauma. You know, they talk about the golden hour
the
for
golden
trauma.
hour.
So there's a
This is
golden
the golden
hour
3
for
hours.
sepsis.
Absolutely.
Do all hospitals do this?
I know that in our area we're definitely the leaders
Okay.
with the code sepsis and the sepsis protocol and the outcomes.
And the wonderful outcomes.
Absolutely.
Right.
I think we incorporated this from the national literature.
Right.
From Johns Hopkins.
Well, I mean, you would say, too, that our hospital, because of the complexity of the patients that we treat, we're the trauma center, we're the regional perinatal center, we're the only open heart surgery center in the area, we have the expertise to be able to treat these really critical patients where some of the other community hospitals may not.
Absolutely. And talking about perinatal, since you bring it up, I mean, we are definitely the center for high-risk OB, and I have to tell you, all the high-risk obstetric patients, after they have their babies, or even sometimes before they have their babies, if things go wrong, we're in charge of handling these patients.
You handle even the high-risk perinatal patients in the medical intensive care unit.
Absolutely.
And good outcomes with those folks, too?
Well,
Because they're
so
pregnant,
far,
and
so
that kind of
far.
complicates matters, right?
It complicates matters to a great degree. I mean, these are mothers who are the most salvageable of all patients, who need to live for their children. And so it's a very high-stress job, but I think we're happy with our outcomes. So far, we've done well.
And yeah, I know every once in a while we'll see a mom end up in the intensive care unit. We have to deliver the baby early. The baby goes to the NICU, but great outcomes. I mean, we have moms who attest to the wonderful care that you guys provide.
Oh, yeah, we've had some great cases.
And that's really unique for our hospital, because to have that ability to have our OB physicians and the medical intensivist and the surgeons and everybody working together really creates a unique environment for patients that you probably wouldn't see at the other hospitals in the area.
I agree with you. And in fact, I think the high-risk OB gets transferred to us from the area hospitals.
They do.
So when they have their critical patients, they come to our unit.
They're coming to Jersey City Medical Center. Okay. Wow, that's really, really an intensive, it must be very stressful, right?
Very stressful. Those are the most stressful patients.
Look, but you don't look like you even think about stress at all.
No, we think, believe me. Those are the ones that we wake up and come in for.
In the middle of the night, and you're worried about it. You want to
Absolutely.
make sure that they have a good outcome, for sure. Especially, I mean,
Yes.
we want a good outcome for
For
everybody who walks
everybody,
through our
but
door.
like I said, these
But
are the most critical patients, because I think pregnancy is a complex physiology, and it adds to the whole drama of things that happens with the body.
Sure. Well, that was a great discussion about medical intensive care. We'll come back and talk a little bit about pulmonary. We'll be right back.
Jersey City Medical Center, Hudson County's #1 hospital, as ranked by U.S. News and World Report. Hudson County's only hospital to receive an A safety score rating. Jersey City Medical Center is Hudson County's only hospital to receive the prestigious Magnet Award for Nursing Excellence. Make the #1 hospital in Hudson County your first choice for quality health care. Jersey City Medical Center. Visit us on the web at libertyhealth.org. Jersey City Medical Center, Hudson County's #1 hospital, as ranked by the U.S. News and World Report. Why? Because of its patient care, not its bottom line. Jersey City Medical Center, for patients, not for profit. The Jersey City Medical Center accepts all patients and most insurance. At the Jersey City Medical Center, your health is our concern, not our bottom line. Make Hudson County's #1 hospital your first choice. The Jersey City Medical Center, for patients, not for profit. Visit us on the web at libertyhealth.org.
Welcome back. We're here with Dr. Jyoti Matta. Dr. Matta, in addition to helping us manage our medical intensive care unit, is also a pulmonologist. So let's talk a little bit about lungs and how people keep their lungs healthy. Tell us what you see mostly, people who come to your office. You're in the medical office building,
That's right?
In the Christie Kerr building?
Right, exactly. I'm in the Christie Kerr building. Our office is on the 4th floor. It's me and my 2 partners.
Right.
And we're all pulmonologists. And primarily, I think what we end up seeing is a lot of COPD and asthma.
Okay. And tell everybody what COPD is.
So COPD is chronic obstructive pulmonary disease. It's some people call it bronchitis. Some people call it emphysema.
But essentially, it's
a disease of the airways and the lungs.
All right. And they're not. They're getting obstructed?
They're getting obstructed. So the airways are getting damaged. They're getting damaged over the course of years and months, probably, and the most common cause being cigarette smoking.
Okay.
And of course we live in an inner city. There's a touch of environmental pollution here, the dust and so on.
Right.
So there's a very small subset of patients who are either passive smokers, who've been exposed to partners who are smokers, or who have just the indigent environmental pollutants that they're at a risk for that can obstruct their lungs.
So let's talk about smoking first. Not only is it the people who smoke the cigarettes, but if somebody else is in the room with them, they also get exposed to the cigarette smoke.
They do.
And what those things, long-term exposure to cigarette smoke is dangerous.
I think it is dangerous. And, especially I think what's been shown very well in the literature is that if the mother smokes while she's pregnant, or if there's somebody in the house that smokes while the mother is pregnant with a child, that child has a great predisposition to develop asthma.
Wow.
As a young toddler, up to the age of 10 years.
Wow.
So I think that in itself is an intrinsic predisposition to creating more asthma.
So let's educate everyone about some lung conditions. So you have chronic obstructive pulmonary disease and you have asthma. What's the difference?
Asthma tends to be a disease of more the younger population. Like I said, it's more reactive.
Okay.
They take their medication, they feel better.
I see.
It's an insult from the environment that does it.
Okay.
With obstructive lung disease, it's more a chronic process. It's damage that's taken place over the course of years, and it's sustained, and it's not reversible.
So someone might get an asthma attack because the pollen in the air is really bad, and it affects their lungs. You give them a medication, and most times they do better.
For the most part, they do okay.
Okay.
Yeah.
And where chronic obstructive pulmonary disease is exposure over a long period of time, and their lungs just can't bounce back the way they used to.
No, they can never bounce back, actually. It's an irreversible condition.
Oh, it is? Okay.
Yep.
And so let's talk about COPD. How do we treat COPD?
It's a complex approach. It's a wholesome approach in the sense that there's a lot of inhalers and medications out there that these patients can use.
Okay.
They don't necessarily preserve the remaining lung function, but they help them breathe a little better. They improve their symptoms somewhat.
Okay.
The lungs will decline as their age goes on, particularly if they don't stop smoking.
And by decline, you mean they just don't have
worse,
the capacity to
breathe.
To breathe. Wow.
They don't have the capacity to breathe. They may end up, on oxygen. They may end up with a very poor quality of life, not being able to function the way they want to.
Wow.
And I think the most notorious thing is the cigarette smoking, in the sense if they don't stop smoking, that decline will happen much faster.
So obviously the number one thing to prevent COPD is to stop smoking. All right, and we have a couple.
We do, actually. In our hospital, we have a little smoking cessation clinic that was set up a few years ago.
All right.
It's run on Fridays.
Okay.
It's headed by Dr. Marchioni, and a lot of pulmonologists refer to him.
Okay.
Because, having a patient stop smoking and smoking cessation, it's sort of like being in an Alcoholic Anonymous program where you need a lot of cognitive behavioral therapy, you need social support, you need help, you need counseling, and medication sometimes.
Sure.
So we have that.
In my wild youth, I used to smoke, and it was probably the hardest thing I did to try to stop smoking, because it's so addictive. That nicotine is just really, really hard to give up.
It is the hardest addiction to give up. Yep.
Yeah. But Dr. Marchione has good results with helping people stop smoking.
I think he does. I think the patients like
and
him.
he uses a whole bunch of different modalities. He might use some
He
medications.
does. And he has his own therapist in the program.
And he has his own therapist in the program.
And that, I think, helps tremendously.
That's really great. Okay. So now let's talk about asthma. So you've got people who get exposed to something and it causes them to have trouble breathing. And essentially, tell us a little bit about that.
Well, asthma is a tough disease. It's an inflammatory disease.
Okay.
It's the airways. They react. They react very suddenly to what's in the environment.
Okay.
It could be dust. It could be pollen, like you said. I mean,
could be secondhand smoke.
It could be secondhand smoke. It could be perfumes. It could be any irritant.
Right.
But the whole idea is when the lungs react so badly, if the patient doesn't have their inhalers, or they don't take their rescue therapy instantly, it could be a fatal disease. I mean, we've seen that happen over the years. 2 cases a year that we see in the ICU every year with sudden onset asthma that the patient could not get rescue medication in time for.
Okay. So tell me what rescue medication.
Rescue medications, these are medications or inhalers that you see asthmatics carrying around, these little pumps.
Right.
They're supposed to take a couple of inhalations right away to help relieve the symptom.
I see.
But asthma can be, in some patients, such an acute onset, or it could...
Is it almost like spastic?
Spastic to the point that if they don't get help within a few minutes or seconds, they can end up in a respiratory collapse. And we've seen that happen a couple of times a year. So that's where I think the education comes in. They're young patients, they feel fine once they're on medications, and then they stop using their medications because they feel it's all okay.
Don't really need it, right.
They don't realize, how quickly this disease can manifest itself.
And it can be just like that?
Absolutely.
Wow, that's pretty amazing.
Yeah.
So what types of medications do you use to treat asthma? So you talked about the inhalers.
A whole bunch of inhalers. Some of them are anti-inflammatories. And the whole idea is, since this is an inflammation of the airways, these inhalers, when taken on a regular basis, relieve that inflammation.
Okay.
And then
what type of drugs are in those inhalers?
Usually steroids, but very low dose. I mean, the whole idea is because they're inhaled, they don't get absorbed into the body, so it's not like you have side effects from the inhaled steroids.
Okay.
But there's that fear factor that a lot of patients have.
So when they use their inhaler, it's just a local effect.
It's
and
just
a lot of it doesn't get
absorbed
it's
into
kind
the
of like
body.
almost rubbing hydrocortisone cream on your skin.
Yes,
right.
Yeah.
Except you're inhaling it into your lungs.
Yes.
And so that reduces that inflammatory response,
It
and
does.
Patients then are able to breathe a lot easier.
Able to breathe, able to carry on activities of daily living, get to their jobs, get to their kids' games.
Now, are there other types of medications you might also have in an inhaler? Other than steroids?
Yes, so then the other inhalers, which I kept referring to as rescue earlier, these are just medications that work on the airway and instantly relieve the spasm. So these are sort of like antispasmodics, something like when we have diarrhea and we take something to relieve the pain, something along those lines.
Okay, so they inhale that and it just,
and
then it really does
better.
start, or stop the Now, when we see patients coming into the emergency department with asthma, we immediately, obviously, evaluate those patients. And now, I see a lot of them sometimes get admitted also.
A very few of them get admitted. I mean, I remember being a fellow in training, and almost every asthmatic used to be admitted. I think a lot has changed with the advent of new medication over the last 10 years.
Okay.
We see a lot of asthma, I'm sure, in the emergency room, given we are in a city.
Now, do you spend a lot of time in your office talking to patients and educating them about the importance of carrying their medication?
That's primarily the course of that visit. I mean, it's the education and education and education on use of these inhalers. It's a repetition over and over again.
Okay. So if you're an asthmatic, you should always make sure you have your medication close by and not just stop taking it because you think you're feeling better.
Yes, I flash it at my patients
and
say,
if you want an expert, Dr. Matta obviously knows what she's talking about when it comes to asthma. We'll be right back. We're going to talk a little bit about sleep medicine. It's another one of Dr. Matta's specialty. We'll be right back.
It takes more than a state-of-the-art medical facility to make a great hospital. It takes a team of dedicated medical professionals. That's the Jersey City Medical Center, Hudson County's #1 hospital. Medical teams consisting of New Jersey's top doctors, Magnet Award-winning nurses, and accomplished hospital associates, all committed to your good health. That's what you have at the Jersey City Medical Center. Make Hudson County's #1 hospital your first choice. The Jersey City Medical Center. On the web at libertyhealth.org.
Panapinto Properties, Jersey City. Shaping the workplace with state-of-the-art office space and an address your company desires. Building residences that define your home environment. Adjacent to all modes of transportation. On-site parking available. The right address, the right lease. 201-521-9000 or visit on the web at panapintoproperties.com. Panapinto Properties, building Jersey City for everyone.
Welcome back. We're here with Dr. Jyoti Matta. We talked about our medical intensive care and the care that you provide for those really, really sick patients and those septic patients. Talked a little bit about asthma. You know, one of the things that I think you encounter every once in a while is the environment in which the people live. We talked about some of the things that could
Yes.
potentially impact patients. How about like their air conditioning, and isn't that something that people should be concerned about?
Absolutely. You know, the air conditioning vents, the ducts, especially in an inner city with all the traffic and the pollution, they tend to get dirty. And I think cleaning of those, you know, with dust mite being the most powerful trigger for asthma,
Wow.
is an important issue. The other thing I sometimes discuss with my patients, particularly in the winter when the air and the heat is so dry,
Right.
is the use of humidifiers.
Okay.
You know, there's the cold mist, the warm mist.
So you're really trying to stop any kind of
Absolutely.
pollutant from getting into their lungs that would trigger
Yes.
that kind of attack.
Yes.
And so are there companies that go around and look at your air conditioning systems? And
Oh, I'm sure.
There are,
Yeah,
okay.
they,
And there are people that
would
can
come
go
and
in there
clean the
help
ducts
that.
out for sure.
Okay.
Yeah.
So you really do a lot of different things. So you help us in the medical intensive care, obviously all related to pulmonary. You treat asthmatics and patients with chronic obstructive pulmonary disease. But you also do sleep disorders.
That's
'Cause
right.
And you're certified in
Board
sleep.
certified in
You're
sleep
board
disorders.
certified. And that's not all pulmonologists are board certified in sleep.
No,
right?
it's an extra added specialty.
Okay.
Subspecialty.
So talk a little bit about what that sleep program is all about.
You know, it's a very fascinating specialty, at least
Mm-hmm.
to me it is.
Okay.
It's a small subset of my outpatient practice and something I really look forward to doing.
Okay.
I treat a diverse variety of situations. A lot of people come in with complaining of not being able to sleep at night
Okay.
or feeling very sleepy during the day.
All right.
Those happen to be the two most common complaints. And there's a whole slew of disorders that we can come up with. I mean, I treat sleep apnea, I treat narcolepsy,
Okay.
I treat restless legs, I treat all kinds of insomnia.
Mm.
And hopefully, I'm thinking, you know, when we have our own sleep disorder center,
Yeah.
which is up
We're working
and
on.
coming and
Yes.
in the making
Yeah.
soon,
Absolutely.
so we'll do it the right
That's
way.
a hint for me, everybody, that I got to get a sleep center up and running at the medical center.
Absolutely. So we'll do it the right way. You
Right.
know, I just came back from the sleep meeting in Baltimore last
Okay.
weekend, the national meeting.
Right.
I mean, there's a lot of exciting things happening, and I think the way medicine will be practiced in the future, the only way for a sleep disorder center to have a great outcome would be to be a part of the hospital with the support
Okay.
systems involved.
Right.
Because it is a multidimensional specialty. It does require a therapist. It does require input from an ENT
Okay.
surgeon.
So someone comes to you, they're having trouble sleeping, or they say they feel tired during the day, and you order one of these sleep studies. What's involved?
A complex overnight testing that's
Okay.
involved. The patient requires to sleep in a little bedroom.
All
It's
right.
a part of the sleep lab.
Right.
There's a whole bunch of intricate wires and things that get hooked on.
Okay.
There's measuring
Is
of
it
the
painful?
Not at all. In fact, not at all.
No?
My daughter just had one, and it's
Okay,
fine.
okay.
So the whole idea is to check and see what stage of sleep they're in,
I see.
how the breathing disturbance manifests itself,
Okay.
if there are any abnormal behaviors during sleep. There are patients that act out their dreams.
Oh,
There are
really?
violent movements.
Wow.
There's all kinds of epilepsy happens during sleep.
Wow.
So there's a lot of fascinating
So you
stuff.
really could find a lot of things when somebody's
sure.
sleeping. So they actually go into a bedroom, there's a monitor there,
There's a
they've
monitor,
got
there's
some
a
electrodes
video.
on there, and
Right.
there's a video, and people are watching them while
Yes.
they sleep. Do they
Yep.
usually sleep all night long, or is that?
For the most part, they
Okay.
do. There's no television, there's no stimulation. I mean,
Right.
they have to sleep.
And they have to sleep. So what are some of the causes and what are some of the problems that you discover through the sleep lab? I mean, people who snore, is that who?
That is the biggest population.
is.
The ones that snore, that obstruct their airways when
Okay.
they sleep,
I
they
see.
stop breathing during their sleep, the blood oxygen
Really?
level trends down.
Wow.
They have very disrupted sleep qualities.
Huh.
And when they wake up in the morning, they're extremely tired, they're
Right.
fatigued. And I think the most important thing that's overlooked is the consequence this all has on the cardiovascular health of the patient.
Wow.
So untreated sleep apnea can cause strokes, it can cause heart attacks.
Wow.
It's been linked to sudden death in
Huh.
sleep. It's been linked now to metabolic syndrome and poorly controlled diabetes
Wow.
and blood sugars of these patients, which